Welcome to our instructional video on airway management in patients with suspected COVID-19. The first and most important thing is to be mentally prepared for the management of these patients. The key principles to consider in this are safety, simplicity, and familiarity with the equipment you'll be using. When preparing to manage the suspected COVID-19 patient requiring intubation, ideally the patient should be moved to a negative pressure isolation room to minimize staff exposure to aerosolized droplets. If such a room is unavailable, the next best option to consider would be a room with a closed door. Prior to entering the patient's room, don the currently recommended personal protective equipment. At the time of filming, this includes an N95 face mask, eye protection, a gown, and gloves. Another important principle in managing these patients is to minimize exposure by minimizing the number of individuals entering the patient's room. In general, people entering the room should include an intubating physician, a nurse to provide medication delivery and any other patient care necessities, a respiratory therapist to assist with the procedure of intubation and setup of the mechanical ventilator, and, depending on the clinical scenario, a fourth staff person to assist with patient care needs. Individuals that stay outside the room generally will include a nurse runner to acquire and provide to the inside nurse any equipment necessary, and, where available, a pharmacist to assist with medication management and preparation. The amount of equipment brought into the room should also be kept to a minimum. For the procedure of intubation, current recommendations are to bring in a video laryngoscope with a blade to the intubator's chosen size and style, an endotracheal tube, a single endotracheal tube, sized per the intubator's preference, and a stylet or bougie, depending again on the intubator's preference. Rescue devices such as an LMA should be left outside the room and provided by the nurse runner to the inside team on an as-needed basis. There are additional equipment setup considerations once inside the room. If possible, and under ideal circumstances, these can be set up prior to the patient's arrival in the room, and they relate specifically to setup of the mechanical ventilator circuit and setup of the bag valve mask circuit, which should ideally only be used as a measure of last resort. The mechanical ventilator circuit will often be prepared by a respiratory therapist. Special consideration should be taken to ensure that the circuit is complete prior to the procedure of intubation. A complete circuit in this case will generally include an inline suctioning ballard with extension tubing, a condenser humidifier, waveform capnography, a Y circuit, and most importantly, a viral filter on the expiratory limb of the mechanical ventilator circuit. The bag valve mask circuit should also be prepared prior to patient's arrival if possible. A complete circuit in this instance includes the bag attached to wall oxygen, a PEEP valve on the expiratory port, and a viral filter, which again is the most important component of this circuit. Notice how the viral filter is connected to this aspect of the BVM. This part of the filter will attach to either the endotracheal tube, the LMA, or, if used as a measure of last resort, the mask. Please remember as well, as with any standard intubation, to have prepared a suction catheter, suction tubing, and a functional suction canister. Now on to the procedure itself. Pre-oxygenation poses a particular challenge in these patients. Namely, we wish to minimize the number and types of procedures that can generate droplet aerosolization, the most important of which is bag valve mask ventilation. Therefore, pre-oxygenation in these patients should be undertaken with non-rebreather face mask oxygen supplementation at about 15 liters per minute. Sometimes patients have nasal cannula devices applied as well. The non-rebreather device can be applied on top of a pre-existing nasal cannula device. If the situation arises that this setup does not achieve adequate pre-oxygenation, one can consider the administration of sedatives and paralytics to facilitate the insertion of a supraglottic airway, such as a standard LMA, an intubating LMA, or any other supraglottic device. Once this is inserted, oxygen can be provided either by a pre-set up mechanical ventilator circuit or the bag valve mask circuit, preference being for the mechanical ventilator circuit. Once you've achieved acceptable pre-oxygenation, proceed with RSI per your current practice. Special modifications to consider in this case are the use of non-depolarizing paralytics in particular, as you want to minimize the incidence of coughing and, again, droplet aerosolization. Administer the sedative and paralytic per your typical practice, and once ready to perform endotracheal intubation, remove the non-rebreather face mask. If a nasal cannula is in place, leave that in place. Proceed with endotracheal intubation per your standard practice. Have an assistant provide you with the endotracheal tube. Visualize going through the endotracheal cords as one method of tube conformation. Have the stylet removed. Inflate the balloon as per standard practice, and then have an assistant bring you immediately the mechanical ventilator circuit. This is in contradistinction to most folks' standard practice, which would be application of the BVM circuit to the endotracheal tube. Given this change in recommendations, tube conformation must be considered as well. Observe for bilateral chest rise. Then look at your monitor and observe for appropriate waveform capnometry readings to confirm endotracheal placement. You can also make sure that the patient is appropriately oxygenating, and if available, use a disposable stethoscope dedicated to the patient, having a single assistant auscultate for bilateral breath sounds. As with any intubation, we will take all precautions to optimize our chance at first pass success. However, as we know, this may not always be achievable. In this instance, we're making a different recommendation from what may be your standard practice. Call for a laryngeal mask airway rather than applying BVM. Have a runner outside hand the LMA to someone inside and bring it to the head of the bed. Again, do not perform bag valve mask ventilation, as that is an aerosol generating procedure. Once the LMA is available, or an intubating LMA, depending on your preference, insert the LMA, inflate the LMA, and provide oxygen and ventilation either with the bag valve mask circuit or, if able, through the mechanical ventilator circuit, noting that there may be some pressure alarms and other considerations in this instance. It is okay to use a bag valve mask, however. After insertion of the laryngeal mask airway and successful rescue of the patient, you can proceed with second and third looks, generally per your usual practice. Our specific recommendations are to consider the following pathway. First, if it appeared that there would be adequate visualization of the cords and a second attempt with video laryngoscopy would be successful, we would recommend proceeding with a second attempt at video laryngoscopy. Consider strongly the use of adjunctive devices such as a bougie. Many clinicians also strongly advocate for the use of bougie devices on the initial pass, but care must be taken to utilize standard geometry blades if that is to be undertaken. Oftentimes it's difficult to utilize the bougie around hyperangulated geometry. If that is unsuccessful, you can again insert the LMA, or in this case, we would also strongly recommend use of an intubating LMA. The intubating LMA has the benefit of carrying dual capacity insofar as it is both a rescue device and then can facilitate a single transition to an endotracheal tube via the endotracheal tube tract. This also minimizes the number of times the patient's circuit is exposed and minimizes droplet aerosolization. As with any intubation, if none of these measures are successful, we recommend rapid consideration of front of neck access with a kyphothyroidotomy. Again, all of these measures and all of these adjunctive devices will remain outside the patient's room to minimize equipment waste. Have a runner provide that equipment to the interior nurse or other provider and then bring to the head of the bed to perform these procedures. Take particular care when performing front of neck access in these patients, as there is often significant aerosolization of blood and other tissue. Lastly, we want to touch on appropriate mechanical ventilator settings for these patients. Of note, these settings need to be provided to the respiratory therapist prior to intubation or concomitant with that procedure, so as to allow the ventilator to be ready to go when attached to the endotracheal tube after intubation. Settings in general are pretty typical for what we've been recommending recently. For most men in the United States, the predicted body weight is 70 kilos. So we're recommending application of a tidal volume of 500 cc's for all males that you intubate in this situation. That equates to about 7.8 cc's per kilogram of predicted body weight. Select a respiratory rate of about 16 to 18 breaths per minute, an FiO2 of 100% to start, and a PEEP of 5 to 8 centimeters of water, depending on the clinical scenario. For females, select a tidal volume of 450 cc's. U.S. Census data suggests that the average U.S. female has a predicted body weight of 55 kilograms, which equates, with respect to the 450 cc's, of about 8.3 cc's per kilogram of predicted body weight. Make sure again that this is set up prior to attachment to the endotracheal tube so as to allow for immediate delivery of oxygenation and appropriate ventilation of the patient. We wanted to conclude with some special points of emphasis and other tips. Consider insertion of an orogastric tube or a nasogastric tube at this time, and then obtain a chest x-ray to confirm tube placement. That allows for minimization of procedures and minimizes the exposure of the portable x-ray machine and x-ray tech to the patient. Secondarily, ensure that you're using waveform capnometry inline. Have all of this mechanical ventilator circuit set up prior to intubation. Do not use colorimetric and tidal capnography. Finally, we want to emphasize very strongly that you need to take all measures to ensure your safety and the safety of others around you. Minimize aerosol generating procedures. Avoid the bag valve mask unless absolutely necessary. If you're going to apply the bag valve mask, use the vice grip. Have it on the patient's face, a V like this. Pull the jaw up into the mask and apply the mask with a very tight seal. There should be no use of one provider bag valve mask support in this patient population. Lastly, simplify things. Have a process in place ahead of time so that less equipment is used and things that you're comfortable with are used. We've just laid out our recommendations for this patient population, but you want to optimize first pass success. The fewer the number of times you're accessing the patient's lung tree, the better. That's the key principle here. One final thought. The best thing that you can do for these patients is to keep them very deeply sedated to minimize the risk of emergence, coughing, and potential tube dislodgement. Unlike what we've been doing in recent years, target a RASS goal of -2 to -4 as opposed to our typical 0 to -1 until the patient is appropriately transported and does not pose a risk to any providers encountering the patient. Thank you very much for watching this video.